Thank you so much, Dr. Matar. So it's a pleasure to be here. And I know everybody's eating lunch, so we're going to make this a little interactive. We always learn from each other, and this is kind of a good opportunity for this. Yesterday I gave a talk, and Dr. Chet Hamill, who's sitting here in the front, came up right after the talk and grabbed me and basically was like, let me school you on what you just said wrong. And I looked it up, and actually he was right. So for once it happened. So we're going to talk about the best practices. Now, this is not based on what I do. This is based on the fact that I just finished 7 years on the accreditation process, so basically visiting a lot of programs. And when we do that, part of the reviewer's job is to basically say, what's a best practice? And so we note this. So this is kind of a combination of what you all do. And I have no disclosures relevant to this, but we're going to do this in a little bit of a fun manner. We're going to basically go over what we think is the top 10 really, kind of best practices done out there. And what I would like to do is, if you feel like this is something you do well, maybe raise your hand. It would be nice to kind of know a good way to kind of interact with each other. If nobody raises their hand, I'll tell you something about me. I live with a turtle, so silence is actually something I'm very comfortable with. Like if nothing is happening, I feel like it's home. And if I ask a question, nobody answers, I'm the only one that's not feeling weird about it. So we'll just see how awkward we can make this. So the 10, there we go. Okay, 10, annually updating Fellowship Council website. I'll tell you why this is a really good best practice, but who does that? Wonderful, that's awesome. Okay, and there's a lot of really good reasons to do this. I mean, some people even don't update it for years, and what happens is they end up matching somebody they can't take, which is a disaster, because then you have all kinds of issues. But also that you have fellows who come in and say, you know what, I really wanted to do lap whipples because you do lap whipples, and it's clearly on the website that says, no, that's actually the other fellow, or that's not part of this program. And so having truth in advertising and updating your website cannot be overemphasized. And it's a simple thing. You have full access to it. Nobody's going to do it except you. Fellowship Council is not going to do it for you. And so that's certainly a good thing to learn from some people. And some people do it well, others don't. Okay, training your fellow in leadership and even actually service line development. If you're a bariatric, how to start a bariatric program. Who does that? Well, okay, look around. There's 3 people. Tackle those 4 people. Okay, this is huge for fellows. Year after year, fellows talk about how this is actually a huge pearl for them. And I encourage you, if you do that, put it on your website, make sure it's clear, you'll get much higher quality fellows. And if you don't do that, you really should consider doing that. It's really something that you all did at some point in your life, and it's something that fellows really care about. ERAS training, things like this. It's not just about technical training. Are they, for the fellows in the room, anybody want to raise their hand who actually has had this through their fellowship? Oh, it's either they're shy or, there it is, one person. Can you tell us where you are? Fantastic. So I know it's kind of low. Yeah, she's at St. Luke's in St. Vincent's, and in Indianapolis, and training in M&M and Tumor Board, and is what I heard, correct? So, and service line development, leadership. These are huge skills that, remember, this is their terminal training. It's a horrible word, terminal training, but that's it. It's like after that, they just go into practice. So if we're not putting that as part of our curricula, we're missing something. So this is huge. Number 9. So let's go to number 8. Keeping the peace between residents and fellows. This is a huge problem, okay? Some people do it very well, and some people don't. Who thinks they've mastered this? Sir? Is that Demetrius? Yeah, tell us what you do. Yeah, so there's different ways out there, but, everybody does it a little differently, and nobody's going to be, there's not one answer. It depends on where you are. But I think the answer is the learning has to happen together. They need to learn together, but at the same time, there needs to be clear lines of who's in charge of what. I found that many programs, they basically put the chief resident in charge of case division, which actually kind of lets them feel like they're still, or that makes them feel still in charge, which I think keeps the peace. Separate teams, like Demetrius mentioned, are an important thing, but again, keeping the learning together, I think, is essential. So, okay. Number 7, feedback and evaluation. Okay, so this is, obviously we have the quarterly technical evals, and then we also have the quarterly case log reviews, which I'm hoping everybody's doing. But there's more to that. Structured evaluation in the operating room, pre and intra and post-operative teaching in a modular fashion. Who feels that they have something unique that they do in the operating room that's not just corrective learning? Now, I think, feedback, unfortunately, is a very confusing topic. I mean, if you ask just general surgery, like ACGME survey, 70% of all faculty say that they give excellent feedback, and 20% of all residents say they get feedback. So there's obviously a problem in definition. But, just telling somebody, don't cut this, move, don't pull so hard, things like that, that's not really feedback, that's corrective action. But in terms of structured feedback in the operating room, anybody have a specific, come on, somebody's got to have some kind of a program. There, can you tell us? Perfect, so I'm sorry, and where are you? In Orlando, right? Sorry. Yeah, so Orlando colorectal, and that's the idea of after the case, having a debrief on exactly what you learned. Other people, other programs, I know Methodist does a really nice way by actually saying what part of the case are we focusing on, and then debriefing on that on paper for a specific part of the case. Again, having something structured is way, way better in terms of learning. Sir? Could not, I mean, that is perfect. If fellows know that they're going to be asked right before the case, what are we learning today? What are your goals? What part of the case we're focusing on? And that's from Mount Sinai, New York. They will come more prepared, and they'll come with a plan, as opposed to saying, oh, I just want to learn how to do a laparoscopic, gastric bypass. Well, what part of it? I mean, so just be more specific. And if you actually have a plan with them, for them telling them, I'm going to ask you this, they'll come in prepared. So, awesome. Okay, so number 6, teaching in the operating room. We just discussed that a little bit, but it's a little bit, kind of different in the sense of, what I meant to bring this up is to basically say a big picture plan, saying, for example, where do my fellows struggle in the operating room, and how can I actually make a structured way to actually help them so that also that they're learning in the simulation center, and then that I'm giving them feedback targeted at deficits, okay? Now, this includes videotaping all fellows and reviewing it, includes shared expectations of basically saying, you know what, you're not a medical student, a resident anymore. You're basically, this is it. This is your last training. So you need to be involved in practicing. So who can tell us about what they do in terms of an overall structural plan to help improve their learning curve in the operating room? I know there are people out there that are doing it.
Adnan,
sorry.
It's not exactly that, but the other reason I really strongly encourage videotaping all the cases, and we encourage all our fellows to get, a big drive, and then really save not only the complicated cases, but to really develop a library of some of the basic cases. Because what we found is our former fellows tell us, when they go out into practice, sometimes it takes them months to get that first bypass or that first complex foregut case. And so it'll be 6 months of them not seeing one. And so they like being able to go back and watch that library, in those evenings before they get ready to do that first case as an attending. Yeah. And they need those simple routine cases, not just that really hard case that they taped to put a video on at Sages.
Sure.
And I was just going to comment that I actually quite like the operative report for that reason, because I actually like our fellows to dictate the operative report, which unfortunately due to some hospital regulations that's not always able, but it lets me know what they got out of that case, because if they said, we entered the abdomen and the head of the pancreas was out, I know that they didn't understand the steps of that case.
So and now that you have a mic, how do you get that? How do you get them to do that? We're talking, or Portland, Oregon, talking about fellows self-reflecting, not just on the technique, but also the overall experience in the operating room. If I get that right.
Well, my current fellow would tell you that 2 months in we had a conversation, and I finally said to him, I said, "Do you understand why you're not doing more of the operation?" And he's like, "No." And I'm like, "Because you're not prepared when you're coming in here. I expect you to be much more prepared than you are." And I can tell you within a week, completely changed. So I give them specific consequences. I'm only going to allow you a certain amount of time to operate, and if you can't figure it out outside of this room, how to shorten the time that you're doing this, you're just not going to do as much.
And that goes to speaking about, setting the expectations to be an adult learner, and it's amazing how many people will actually rise to that bar. Yeah, please, sir.
Abdel Nimeri, Carolinas Medical Center in Charlotte. So one of the things I do in gastric bypass is we separate the procedure in two parts.
Yeah.
So the first part involves putting the ports, the JJ, closure the defect, and dividing the omentum. And the second part is making the pouch and making the gastrojejunostomy. So when we start, they have an hour to do the first part while I basically just hold the camera. And we spend at the beginning some time in the simulation lab in a process that simulates the JJ and the gastro-J, showing them exactly how they need to do it in the lab. We use unedited videos for them to watch the procedure. And then when they come to surgery, there's a time period where they know exactly how much time they have to complete that task. So every week you see that they're improving and they're doing more of the surgery because they're against a clock. So there's not only coaching, but there's a time period that they have to stop at. And then at a certain point we switch, so I do the first part quickly, then they have the same time clock to finish the surgery.
That's a great idea, and that speaks to the concept of modular teaching, which, again, we've seen some programs do it, which is incredibly loved by fellows. I mean, it really shows progress, so that's good. Okay, so let's go on to number, sir. No, but he actually just moved, so it doesn't really count. Sir.
And the one thing we've shown, we're actually presenting an abstract on it, is it increases confidence, but I'm not sure what else it does. So I don't know if it just gives them a lot more confidence before they operate, but pre-operative edited video seems to help with at least the steps of the case.
There's no question that, getting that, the simple cognitive knowledge, the cognitive element of a psychomotor element out of the way expedites your learning curve in the operating room, because then you really don't have to kind of teach them what actually you're doing. You're just going over the technique itself. Absolutely. So great. Thank you for that. So number 5. Okay, research infrastructure and QI. Now, we know it's a requirement, part of the Fellowship Council, that they're involved in either QI or research infrastructure, and I know I don't know a PD that doesn't want their fellows to do something or publish something, but who actually has an infrastructure to help them or have them go through it that actually teaches them how to do it? Wonderful. A lot of Andy, do you mind sharing with us?
Yeah, sure.
Dimitri? Yeah. Dimitri?
Yeah, go ahead.
Speak up.
Yeah, I'll just speak. So one of the things that we've been able to do at the University of Nebraska Medical Center, by the way, my name is Dmitry Olenikov. I'm director of Fellowship Council. My co-director is sitting right there, Dr. Corrigan McBride, is to set up a infrastructure so that when the clinical fellows come in, they are able to start a research project fairly quickly. That infrastructure includes the following elements. It includes coordination, so administrative support. It includes support for creating a grant, so the fellows understand how to ask for money, how to work on the budget. It includes statisticians that can help the fellow with statistics. And it includes also collaboration with our research residents and a research fellow. So, and I think those things are important because in a one-year fellowship, it's just about impossible to do meaningful research without those things. So I'm very proud that we've been able to do this, and we've had this infrastructure now for over a decade. And we recently looked in this, and our average clinical fellow will graduate with at least 3 reviewed publications published.
And that's in 1 year.
In 1 year.
That's pretty impressive. So this is, thank you for sharing with that. That's an example. Now, some places may say we don't have those resources. Well, at least having a mentoring time to actually sit down with them is a big deal. So certainly look at your resources. So we'll keep moving to stay on time. Faculty professional development. Who actually trains themselves and the faculty in actually how to teach? Who has programs for that? Andy? This actually is a huge national deficit, and there's some places that do simulation training. There's others that do, feedback training. But this is a big deficit, and maybe something that Fellowship Council can look on into it a little bit more. The other thing that we found that's really, really helpful is actually when we actually kind of simulate the curriculum competency committee kind of structure, where there is actually quarterly faculty meetings to include the fellows to actually discuss about everything. It's amazing how, if you ask fellows, how often does this happen? It's very rare. The feedback, it typically comes from the PD, and then that's it. But having go out for dinner or for drinks once every quarter to actually discuss how the fellowship is going is a huge thing, to discuss the 360 evaluations and so on. Now, there are some places that are doing this to an impressive degree. There's one program that actually does a naturalistic observer. They actually basically have everybody, all the faculty and the fellows, and everybody sit down, and actually somebody who's actually either a DIO or another surgeon from a completely different department sits down and just listens to them and then takes notes and then gives them a summary, which I thought was amazing, and something that we're hoping to start. So that's number 3. Number 2 is internal program evaluations. Basically, you do your own site visit. Who does that? Every 3 years, every 2 years? There, yeah. Okay, so 2 programs. Can you tell me where you are and what you do?
I'm the fellowship program coordinator at the University of Nebraska Medical Center. I work with Dmitry Lenikoff and Corey McBride. I
didn't plan
evaluate
this,
us
I
every year. It's just, I want to make sure that my fellows are getting the cases they need. Coming up in May, I will be on them as to what cases that they're short on, and what cases that they have way too many and they should be giving up to the residents. So that's what I do on a regular basis every year.
That's an awesome thing to kind of do on a repeated thing. There are some programs that basically have a PhD educator or have another chair of another department that basically looks at their whole program every 3 years and just gives them a report. And if you do that on the off years that the Fellowship Council is not reviewing you, when the Fellowship Council comes and does a review, they really have nothing else to say. It's all done already, okay? And then, for the best practice out there, and this comes from, I'm a diver, and there's this thing that the divers say: you plan your dive, and we all plan our dive. This is what we're going to do. This is how deep we're going to go. This is where we're going to go. And then you have to dive your plan. You don't just go down there, and then all of a sudden there's a shiny object or there's an animal there, and you go veer off and abandon your plan. So the whole idea is you plan your dive, and you dive your plan. And when we do our fellowships, we always plan our fellowships. We have curricula, we have evaluation, and then guess how many people don't follow them? A lot of people don't follow their plan. So I think the best practice I feel from looking at all these programs is do nothing special except do what your plan is from the beginning. In other words, it's all part of the curriculum. You have your curriculum, you have your evaluations, and following that actually gives you a very solid program. So those are the top 10 things I learned from being on the accreditation committee. Hopefully that was helpful, and thank you.